Sorry, I'll turn on my camera. I'm
There you go.
I'm a Penn resident, sorry, a medicine resident at Penn. I'm rotating with Dr. Erica Reinecke this week on ECT, so she had me log in for this.
Oh, amazing.
Hope that's okay.
I'm, yeah, no, it's always great to have folks that I haven't seen before and folks that have hopefully some fun perspective to share from your week with the Penn ECT team.
Yeah.
Um, I'm curious. I'm growing our program here
Yeah.
and trying to model it. Tufts has a really good rotation with medicine, and, folks on call. Their residents are always on call, and then the critical care folks are part of it. I haven't been able to solidify that part of our program yet. So I'm we're a work in progress that way. I'm trying to get as much exposure to medicine folks, critical care folks, and all the rest. How is that rotation kind of set up for you guys? It's optional or it's like mandatory for medicine residents to go through?
It is optional. Yeah, it's an elective.
Okay.
Yeah.
And if you guys don't have you had cases this week going?
We haven't had any this week, so we do, yeah, I mean, we do like reading, we go through some like interactive lectures, we like practice setting up machines, do like practice prescription writing, that kind of thing.
Okay, cool.
Yeah.
I've got that. We run twice weekly board review for our critical care residents. And I've got about 10 sessions sprinkled throughout the year that are essentially what you just described.
Right.
So they're incorporated into that group's board review sessions. And then I've got a student course that I run, which again, kind of similarly to what you described, but it may be that I've got to offer it as a more full rotation.
Gotcha.
Oh, cool. No, I appreciate the description there.
Yeah,
Do
of
you
course.
do when they're pointed on, or do you?
HB platform, but a small patient. We're just trialing these smaller bloodlines. Parents. May not straight up machine. Yeah, it's always trying to figure it out. I mean, what's that now? No, no fair or two. All right, well, we got Max, Andres, Erica, Talia. We're a couple minutes in. We might give folks one more minute or 2 more minutes to get signed in. I've got a case to chat about, but I think with these sessions, it's always more fun if other folks bring interesting, challenging, cool, or new things to the discussion as well. But I'm going to mute for a minute just while we're. Oh, Alicia might have fixed it.
For 5 seconds.
For 5 seconds. We'll see how long it lasts. We've we've got a small, she is 6.2 kilogram dog with an AKI, probably an acute on chronic, named Molly. And we started her off on our Prismax just because we've got the HF20 set, and so extracorporeal volume wise, it was a nice one, and I like to fine tune and control the treatments on these little guys on the Prismax. We've named ours Priscilla. But we had an HF20 deficit in our warehouse, and so we challenged ourselves to move over to the Blue Star platform with a small volume circuit and an F3 dialyzer. And our IHD platform gets really upset with the small circuit, and we were kind of warned of that when we set it up. So if I don't know if once I kind of explain the problem, if anybody else is using the Blue Star platform and has any workarounds, that would be great. We have, it's 2.6 millimeter sets made by Medibron. It's got a priming volume of 29 mils combined with the F3 dialyzer, which has a priming volume of 24 mils plus our crit line. So we've got a fairly nice small blood volume in the circuit for this patient. But the platform has a couple of places where it gets upset. One is we've got consistent TMP, transmembrane pressure alarms. And it's, I'm not doing any ultrafiltration, and then I do a little bit just to see if I can help just move things. It's a low flux dialyzer, the F3. It's not meant to do a whole lot. And they had warned us when they installed for us last year that the small circuits have an air leak detector chamber that might not be compatible, that might need some special calibration with our machine. So when we set it up a couple weeks ago, it actually worked with flying colors. And so we started using it on the small patients, and we've had a couple of really good treatments. But the first hour or so is, you guys can probably see in the background there, Alicia is just pushing the mute and reset button on our pressure alarms pretty consistently. The other element of these small sets is that they don't actually have pressure lines. Well, there's one pressure line that comes off the venous side. And it hasn't come with one of the little protector discs. So I've introduced that in there, and that has not made our machine any happier. So she settles out eventually, but we kind of live with what we've got going on here for the first hour or so, which unfortunately I was trying to get started earlier before this meeting, but here we are. Erica, do you guys have a Blue Star at Penn?
Hi, Jethro.
Yeah.
We do. It's interesting that you brought this topic up because we have had problems as well with the small circuits, so much that we still have our old Phoenix. So if we need to use a small circuit, we still defer to using the Phoenix because we've been having some difficulties like you described. I can send you, I actually worked with our children's hospital because they have the Blue Stars, and they sent me a way to set up arterial pressure monitoring on the small circuit. So
Tonight, I planned it like a couple minutes ago, but it's just like bleeding back in the syringe. Does it usually bleed back in the syringe?
You give it like a 0.2 mil bolus from the heparin screen. Yeah, that has I had, like, the arterial side doesn't seem to care that I don't have a thing hooked up. From our monitoring perspective, I found other kind of visual ways to see when we're getting high pressures on the access side. I was thinking of just adding an extension line on the priming T part there, and hooking that up to the sensor. We're getting venous side and TMP alarms like crazy though.
yeah.
Were you guys getting those too, or just the access
Yes.
side?
Yes. We get them frequently as well. I don't know if I have any good advice for you because I did speak to Emmanuel at Tufts because we were struggling like you are with kind of nuisance alarms. And when I talked to her, she was like, we don't get those. So I don't know if it's like a calibration thing. I guess if you're getting a lot of TMP alarms, you said you already tried doing ultrafiltration and then you could add fluid back. You could try that, put the dog on some IV fluids. I'm not sure if it'll help or not.
I started with no ultrafiltration, and then I've done like 10 mils an hour right now. And it hasn't really been too much of a difference. That was when we had the install, that was what they suggested. And that's traditionally what I've done, is just have a little bit of ultrafiltration on there, just to keep something moving across the people in town. But my little bit hasn't helped, and I do usually give back whatever I take in as well. Well, I'll have to, maybe I'll reach out to Carol at Tufts and find out what their secrets of success is, if it's calibration or not. When I did ask her, I don't see her on here. When I did reach out, she said they were only calibrated for the 6 millimeter sets, the 6.4s, and when we had our calibration and our setup, we calibrated for the 8mm sets. And 6.4s worked great. It's just been these 2.6s that have been the real struggle for us with these alarms and these nuisances.
Yeah. Yeah, I wish I had more experience to lend to you, but our problem is when I've done it, I think I have a different problem than you. I tend to get air in the inlet side when there's access alarms, like where the pump won't stop. So it seems like you and I are having different problems.
Oh,
Obviously.
I think I've had your problem too,
Okay.
for fun. When my catheter, pulls up against the sidewall, or we would get an access pressure alarm, we get a bunch of air that gets drawn into the line because the pump doesn't stop because it doesn't recognize that, it's got high
Correct.
pressure. So that's been my visual clue to say, all right, and actually I just had that just now that, yeah, I've got a catheter issue. And so I just adjust my catheter until I get flow going again. So by not having that pressure sensor on the arterial or access side, it saves an alarm at least, but it doesn't help with blood flow alert.
Right. Yeah. I mean, the last patient I tried, I mean, it was not a little bit of air. It was like a massive amount of air because I kept getting access alarms after access alarms. And then I had to rinse back. So I have not converted yet to the Blue Star 100%. It's definitely a learning curve.
Yeah, I was tossed up this morning, knowing that we had a couple. I mean, this is our third or fourth treatment for It's like, oh, we're going to be in renal replacement rounds. I'll either show off like something going really well, or it's just going to be a nightmare. And I wish I had done the first max instead.
Isn't that always like how it works when you have something you need to be at? That's been my experience that things are delayed or aren't going as well as you'd like. It's always Murphy's Law, right?
I did. I don't know. Summer might still be in the background there when she'd emailed to say, hey, is anybody available to help with the session on Friday? I was like, well, I've got this case going. Murphy's Law will mean that it will go terribly. I was trying to bypass that. Here we are.
You put it out in the universe, so it was guaranteed to happen.
I was trying to like wish it out of existence.
Yeah, that was the wrong approach there.
Fortunately, I've got I know, as we all do, a big shout out to our team here. Alicia's over here, probably on fire inside, pushing the mute and reset buttons every 2 seconds. But we seem to have hit. Oh, nope, I lied. I'm gonna say we seem to hit a sweet spot here for a minute. Erica, when you set yours up, did you connect that venous pressure side too?
Yeah. We try to do the arterial pressure monitoring by, like you said, adding an extension set with a pressure transducer. And that it definitely helps with access alarms, like it will stop the pump. And yeah, I have hooked up the venous side because I don't think you can run it without a pressure transducer hooked up on the venous side. The alarm, it'll just keep giving you TMP alarms without it being hooked up.
Okay. When I actually did connect it, the TMP went through the roof. If there's any function, a little disc maybe was wet in there. I'll pull out a fresh one here and see it.
Because I think if you disconnect that, at least from my experience, is it gives you, at least when I've done it, it gives you constant TMP alarms when it's disconnected. I could be wrong, but that's been my experience.
No, that's right. We were getting them with it and without it. So
Great.
because even right now, so our TMP is climbing to 80, 90 once I put that pressure sensor on there. So.
And the tubing isn't kinked on like the venous side? Like the line through the clamp and that's all okay? Which is crazy on the Blue Star too, is I don't know if you know this, but you can actually take that line completely out of the air detector clamp, like the clamp, the venous clamp, if you're worried that the venous pressures are high, just to like make sure that that's not the issue. Obviously, you have to watch really closely that no air is in that line, but you can temporarily take it out and see if that helps at all.
By connecting that pressure system. I've gone back and forth with the last treatment, gone back and forth, and we ended up having success without it connected. But
Oh, wow. I'm surprised.
it likes being connected right now.
Yeah, I'm surprised that it let you continue the treatment without it connected. Wow. Interesting.
I'm not saying it went well, but we got the treatment done. I've actually, I mean, it's been a really nice, alternative. The couple of treatments are, total urea reduction has been quite a bit more pronounced with that than it was on, the same, which, makes some sense, than the same time frame of treatments with the, just pulling up my my graph here for you guys too, with the Prismax platform. I'll share this and show you guys.
I'm curious, like I feel like the rinse backs in the Blue Star compared to what I would get on the Phoenix aren't as good in regards to scavenging red cells. I don't know if you've been seeing that. But we will do air rinse backs. I'm not sure if you do that.
I love air rinse backs.
So are you seeing, like, do you feel like the air rinse backs is good? I feel like they're just not as good.
My decision-making point for that is, do I want to give a little bit more volume back? I think, and I've got a bunch of old sets that I've got like in the back of my mind to set up to try and answer this exact question. When I watch the air blood interface like flow through that circuit going back to the patient, just visually, it looks to me like there's more red cell recovery that way rather than when it's, a crystalloid flush through there. It just seems to dilute it. And I end up with this, pinky fluid still in the line after I've rinsed back, the volume of the circuit plus a little bit more just to try and capture a bit more. But it's completely a subjective, I think, assessment, and I could be way off. It's also how my mentor, she was a big fan of it, of air rinse back. And so it was kind of how it was ingrained in me from the start that she felt that way. So, I have carried that forward and maybe that kind of colors my assessment of it. But you're thinking you get better red cell recovery with fluid?
No, I was saying like on the Phoenix machine, when I did an air rinse back, I felt like I got really good red cell recovery.
Oh, I
But
see.
when I've switched to the Blue Star and doing the same, air rinse back, that the recovery of red cells, like I feel like I lose a lot of red cells in the dialyzer. And I don't know if it's because of the longer lines in the Blue Star that are in the circuit compared to the Phoenix. The Phoenix has much longer lines to the patient and shorter lines in the circuit. And I feel like it's flipped in the Blue Star where there's a lot of line in the circuit and less line to the patient. So I don't know, just something I noticed difference. Obviously it's not a huge deal, but I was just curious if you saw that.
I'm every red cell is sacred in my book, so I'm avidly looking for a way to get as many of them back to the patient as possible. I guess cards on the table. It's been since 2019 since I worked on a Phoenix. So I don't have a recent memory to kind of draw on to compare direct to the Blue Star like maybe you've got. It's an interesting question. I mean, I think overall it's an interesting question. Are you doing mainly air rinse backs for most of your treatments?
I was, but now with the Blue Star, I've done more crystalloid rinse backs because I felt like the red cell recovery was poor. But I agree with you, like it gets like pink and it can be a fair amount of volume for the patient.
Yeah. I don't know. Andres, do you guys do more? I don't know if you're in the background there, more air or fluid rinse backs on your treatments?
Hi, how are you?
Hey,
We do a saline rinsebacks. I usually don't do air rinsebacks.
okay.
And I have noticed I lose a little bit of red blood cells in my circuits, but not that much to be really worried about. I was looking at your computer screen. Could I see at your creatinine graph?
Absolutely.
Yeah.
So this is this treatment on day 19, on day 22. These were both on the IHD platform compared to these were all PIRT, the first 7 treatments there.
And do you have a previous creatinine before she became acute?
No, unfortunately, we don't. That would be a
Okay.
nice data point to have. She's got some pretty chronic looking kidneys.
Mhm.
So this is an 8-year-old female spay Bichon who's got a history of being a breeding dog in a puppy mill and was rescued by the current owner. And as we worked up her AKI or her rhezotemia, she did have a pretty nasty E. coli. It was relatively wimpy in terms of what it was sensitive to, but she had a pretty strong growth of E. coli from her urine culture. And on an ultrasound, she had bright tissue around both kidneys, some pilectasia, but also some pretty chronic changes in those kidneys as well. But so yeah, I don't know what baseline we might have started from in terms of her chronic disease, unfortunately.
Sure. I don't know if I missed it, but what's her age?
She's 8 years old.
8. Ah, she's kind of young, yeah.
Yeah.
I usually, when I have acute and chronic disease, it's usually the really old ones, like 16 years old, 13. So I'm a little bit hesitant to treat them because I don't know really how much they're going to recuperate their function, right? So have you considered doing a cystatin B with IDEX to see how the injury is going?
I have given it some thought. We've got a side study going with IDEX, looking at nephrotoxins and CISB, UCISB, and I haven't reached for it in these cases just yet. I guess filling in some of the blanks for us. About 4 days ago now, so this would have been 8 treatments in at about 3 weeks since starting treatment. I had her in on an off dialysis day for a repeat cysto ultrasounds, repeat culture, looking for any active signs of infection. And I've not reached for the UCISB yet as a marker for that. In terms of her ultrasound that she had, kidneys looked like they were fairly chronic. All the acute changes that were noted on the previous ultrasounds were resolving, and the culture didn't grow anything. Are you using more urinary cystatin B in these guys then?
No, actually, I don't have access to it because since I'm not located in the US, well, I could send the sample, but it will take too long to see if actually. Just give me a moment.
I wonder if Erica, are you guys using urinary cystatin B for tracking any of these patients? It's come
Sorry,
up a couple of times. So.
there was too much noise where I was previously. But I was saying that I'm not in the US, so it's a little bit difficult to get the cystatin B marker because it's going to get the results back too late before I will actually make any change, right? But I'm considering sending the samples and just checking what results we get.
I would say I would like to measure urinary cystatin, but we just don't have like great access to it. We have to send it out. It takes a while to get back. So I wouldn't say it's like standard yet for us, although I wish it were.
Here, this is her right kidney. Just you can see how irregular, undulating, and kind of cystic it is. Left kidney also had some loss of corticomedullary distinction too, and still some pilectasia here on the right, similar to when she had her acute ultrasound. This is the repeat follow-up. Well, it has, Andres, I'm glad you brought it up though, because it has come up a number of times in terms of, you know, is it something that we can use to track some sense of recovery, and active inflammation, obviously, because it's, you know, an indication of renal tubular injury. I haven't been able to convince myself, and maybe I should just, you know, try and get some out there, but I haven't been able to convince myself that following the rebound in their creatinine or their BUN like I do doesn't give me the same, I guess, information around recovery versus not. Out this far, you know, I guess if I were using the USSB in Mali, for example, and tracking that, would I use that as an indicator? Listen, there's still a lot of active, you know, disease, even though we're not seeing rebound, you know, to a lower degree with her creatinine yet. Should we keep going? Is that kind of what you're getting at? What your decision-making point might be, Andres?
Yeah, actually, that was kind of what was I wondering, because if you notice, it just doesn't seem like, at least for now, it doesn't seem that it's going to get that much better, right? But if I was wondering if she's really, she really has some clinical signs, or you have noticed any recovery, because maybe that's going to be her new baseline, right?
True enough, you know, at some points, you're right, is, you know, at home right now, she feels really well. She's got an E-tube in. She's getting fed through the E-tube, but she eats relatively, you know, steadily on her own, and that has actually been improving for her. Her activity is good. She's happy and seems to be living her life the way she was before all of this. So yeah, I mean, I guess, you know, the only other way, would I use USSB as the only marker to say, well, 7.2, you know, her most recent creatinine, is that her new baseline? Can she live with that? I guess I'd still be stuck with, well, I've got to give her more time, you know, in the interdialytic period. We adhere pretty tightly to the every 3 days, because I've just found most of my ongoing cases seem to get sicker towards 4 days and 5 days, even when we tried to stretch it out. But that might be a more empiric test for, is 7.2 her new baseline? Can she live with it, I guess? And a decision-making point outside of a biopsy, which, you know, would be the next, you know, discussion point at this stage of things. Is there any structure that's left for us to kind of hope that healing and recovery could take place? And we're getting into that time window. I often, you know, struggle with folks having that conversation, because the cost of us doing the biopsy and sending it out to really tell us, well, is there hope for a little bit of recovery, or is there no hope and we should, you know, expect that we're doing this chronically, you know, for as long as the owners are committed to it. Well, that financial commitment could be put towards 2 more treatments, for example, and another week of time feeling well with the family. And if the rebound in creatinine is not, or the slope, you know, coming back up is not improving, that almost answers that same question. But I think that's,
Yeah,
you know,
absolutely.
loose. Yeah.
I actually wouldn't change anything about the treatment. I think every 3 days is like the minimum you can do right now, because she's doing better. You can still hope for recovery. So I really like this case, but I'm just wondering what to do with my next patient, right? Because it's going to be probably the same scenario, and what to do next. That's probably the same concern my clients are going to have. Like, if we do the biopsy, or we just keep doing chronic dialysis, like, what's the better course for this patient, right?
Yeah, no, that's exactly it. And I think this is where, you know, I'm sure we all have very similar conversations with folks at the start of all this. You know, let's get out to the 3 or 4 week mark and look for a response, or be patient to see a response in that time. I just added in today's creatinine, which is 7.7. So I mean, I think we can safely say in terms of that, she's not got any recovery to this stage of things.
Well,
So,
well, she's still young, so maybe she's going to have more recovery. So as long as they are willing to, that will be great if you can keep going.
yeah, I've got a big collage up on my wall here behind of a number of our patients, and one of the biggest ones up there, and I've shared his story on here before, is Kaz, who was an ethylene glycol dog, and he actually did, after 3.5 months, his numbers plateaued down in the high 4s, low 5s, from being in the 10 to 12 range, at the start of our treatments. So I think that gives me hope to share with folks. Listen, there have been dogs that have made more recovery with patience and time, and the finances that go into it. It's hard with her chronic changes, in the background on ultrasound here to not wonder if we've got a limit to the recovery that can happen, versus Kaz, the ethylene glycol dog, was a 3-year-old border collie with fairly nice architecture to his kidneys outside of the the brights and the medullary rim sign and everything that went along with his ethylene glycol tox. But yeah, these are tough ones when they don't show recovery in this time frame. And we did this week, just going down our differential list. We did acute testing for lepto in the early stages, and then did a MAT this week, as a convalescent, and her titers were all less than 100. Like I said, nothing looked really acute on her ultrasound anymore. And so I do have a lot of concern that we may have this acute on chronic that there's not recovery for. But I'm forever the optimist. I'm the realist balanced with the optimist, and I try and share that viewpoint with folks so that we're on the same page. And this owner is just a beautifully committed woman who's retired, and so she spends all day with Molly, the dog. She brings in some of the most amazing blow by blow, hour by hour data points, typed up of what happens through the day. If I were an internist, I would probably be in love with this client from that perspective. As a criticalist, I'm like, well, I appreciate it from the dialysis standpoint, but it's a lot of info. Well, Erica, I'll tell you, we put that pressure sensor on there, and Alicia had a few alarms from there, and we seem to be running happily now. So
Nice.
that might have been it. That might have been a foolish decision on my part to not have it on there at the start.
I've never been able to do a treatment with that disconnected. It just keeps TMP alarming nonstop. So
Yeah, thanks, Erica.
welcome. I hope that, well, it sounds like it's worked for you before. So
Yeah. Have you, Erica, in that vein, have you abandoned the Blue Star for now then for your smaller guys and stuck with the Phoenix, or are you kind of dabbling again?
well, the Phoenix, we don't have a contract on them anymore. And so obviously the goal was to replace them with the Blue Star. It's interesting. We're struggling more with lots of error from inlet access alarms. And so everybody's very nervous about switching. But no, we'll switch. I just feel like it's something I'm doing wrong, but so when you get air in the circuit is only a little bit when you get the access alarms.
It's so we got a lot of experience with it with one of our chronic patients. We dialyzed for 3 months using the Blue Star, but she was a bigger dog, and so we were using that big circuit, that 8mm circuit, and had no problems really with it at all through that time frame. We weren't getting air in there, and we weren't getting access alarms. It's really just been with the smaller circuit.
Right, because the big circuits have the arterial chamber.
Right. Yeah.
Right.
Just now, so in the midst of, maybe my back was occluding it, but maybe like 20 minutes ago when I leaned over, we had maybe half that access line filled with air. that it just kept pulling it in, and obviously the catheter was sucked up against the cava inside of Molly. But the pump didn't stop, and it pulled all that air in, and then it filled the air detector chamber, and then we got air detector alarms. So I don't know, is that kind of what you're experiencing and
Yes.
describing?
Yes, that's what
Yeah.
happened on my last patient. I put a big dog on a little circuit so that I could, it was a big dog. And I was like,
Hmm.
this will be easier. I don't have to worry about it as much. And yeah, ultimately I had to rinse back because I couldn't get the air. There was so much air that kept getting sucked in. And then I just put the big circuit on the dog. But we'll try again. So you just let the air go through and then you just raise the venous chamber and all's good.
Yeah, I mean, that's what happened. I mean, it was one of like 5 alarms that was going off right at that point.
Yeah.
But yeah, I pulled some of that air out and raised the venous chamber up. Although the air had to, the alarm tripped for air detector, but the level of blood was actually above the level of the detector, so it was kind of weird there. But I pulled it out anyway and pulled up that level and reset that one, and then the TMP and everything else kind of followed with it.
Yeah, I wonder if it was like a little air bubble that was like mixing. Interesting.
Yeah, I've kind of
Yeah,
played around in there.
I think my issue is that it's like if I get access alarm after access alarm, like that's what happened in my patient. Like we thought we troubleshot it, but then it still was pulling air. Like we would turn the pump back on and it was still pulling air. And so, yeah, yeah. I miss the Phoenix when that happens, but here we are. And I think the other struggle on the Blue Star is, if your blood builds up in the venous chamber and goes into your transducer line, that's why I've told you to reattach it, because you basically have to clear that line first of blood and reattach it to kind of get things started again. But it's like a little bit tricky to troubleshoot that, which is obviously on the Phoenix, you didn't have those types of pressure transducer lines. And so it's a new system, new learning. Like,
Yeah, and one of the things that maybe I've been misled on, well, when I use the Purify HP pump, it's the same type of pressure sensors and connections, and those lines often fill up with blood. And so I'm always struggling with those guys. And eventually I just take those pressure pods off and the machine keeps going. The Blue Star, not so happy with that.
makes sense.
Which, I mean, you lose. I mean, it's an important safety, feature and circuit feature. Of course, it's there. Those are there for a reason. But I probably after we get off here, I may try and hook up that access pressure line. As like I said, if I got things going a little sooner and setup had happened a little more smoothly, I was going to try and set up today to have that going as well. The kind of the jerry rigged one. But I've come, the last couple of treatments in this one, I watch her access line like a hawk for any type of, little air bubble starting, or it looked like the pump is, I mean, the pump doesn't struggle, the pump just keeps turning, but you can kind of tell the movement of the line through the changes when it's, sucking up against the cava inside. So those have been things that I've kind of used as surrogates for that access pressure, I guess.
Thanks. That makes sense.
What else with her? I think there was something else I was going to share with you guys on this one.
I'm curious, maybe what other like medications you have her on. Is her phosphorus management been straightforward, or does she have any potassium derangements, all that other fun stuff between treatments that criticalists we all hate?
Yeah, no, what is her blood pressure today? What was the baseline coming in?
104/50, and that was 71 was the first one I wrote down.
Before all we got hooked on? Okay, cool. Great question. So, the handful of chronic / all of those little annoying things in the background. Her phosphorus has been difficult to control. We have her on a pretty high rate of aluminum hydroxide, about that 120 mils per kg per day, with her E-tube feedings, and then mom adds some in addition to that when she eats on her own. I think I'm going to have to switch over to either Sevelamer or I never say it right, but one of the Sinatsalot, I think is the other name of the one, or layer that in, because I've just not been able to get control over that phosphorus. I mean, it's, today it's 10.5. So that's been one of the things that I've had to try and troubleshoot, and I've incrementally been going up with our aluminum hydroxide, and I think I've maxed out on that. So I'm going to have to look at another option there. One of the things that helped in another chronic patient, became chronic, was actually switching to a homemade diet. And that actually remarkably helped a lot with our phosphorus control and our potassium control for that matter. So Molly's potassium today is 6.3. And here I'm happy to share the screen on this too, so that you can actually have a look at it. There we go. Let me know if me scrolling around on it gives anybody any seasickness here. But so let me get some cumulative data here. So you can see her potassium outside. This was an outlier. This was, no, I apologize. This was post-treatment. So pre-treatment, she's been coming in pretty consistently, 5.6, 5.8, 6.6, 6.3. And that I have found she's on KD as a diet through the E-tube, and then she eats, kind of assorted other things on her own. But the getting off the KD and getting onto a home cooked diet formulated by our nutrition service here made a huge difference in our last patient that was struggling with that potassium coming up, and the phosphorus for that matter too. And so I think if this owner is going to continue on in this vein, that's something that I'm going to introduce as an idea for us to try and see if that helps us get some control. I know Calgill is a huge proponent of the chicken and rice. And switching over to that, not quite balanced, not quite, everything nutritionally in there, but he's promoted that for some success in getting the intradialytic potassium and phosphorus a little bit better controlled as well. I don't know, is that, do you have some strategies, Erica, on your end?
No, I appreciate that. I mean, I have the same struggles, and I agree. Probably the home cooked diet is the way to go.
Yeah, the other, she's doing well, holding her proteins okay. The other thing that we've been titrating up on, she's on amlodipine for blood pressure control. And we just increased her to about 0.3 mgs per kg twice a day. We had been cruising along at 0.2 twice a day. And we're still struggling with some pretty dramatically high systolics and MAPs for that matter as well, like in the 180s to 200 still. So finally this morning, after going up earlier in the week, we've been titrating up over the course of the last 3 weeks, and it looks like we finally got her down below that systolic of the 180 to 200 with this new dose. Now, mom is being challenged by it's a 1.5 tablet dose for this dog of the 2.5s. And that's been a little bit of a challenge for mom to get an accurate cutting in half, she said. So she might be a little bit higher, she might be a little bit lower than the actual prescribed dose there. But that is, I mean, Erica, that's a really lovely point on this too, which is, I definitely focus on the acute stage of things, and it's where, my passion for doing these guys in the acute setting is to get them home, get them on the couch with the owners, get them feeling better, control the symptoms, the manifestations of the azotemia. So they're not wasting away, but that's an unfair characterization, but struggling in the hospital. But it doesn't negate the necessity to control all those other chronic elements of kidney disease, even in that, first couple of weeks on dialysis, but certainly as you start getting further out than that as well. The other thing that we are challenged / monitoring and treating with her, and this does sometimes bring up a little bit of I know with my internal medicine group, it brings up a little bit of discussion anyway, but she's had a non-regenerative anemia of chronic disease here related to her kidney injury. And so I'm not shy, and it's come from, again, spending too much time with maybe the cowgirls and my other mentors of the world. I'm not shy about starting these guys on darbepoetin pretty early on, even if they do have some hypertension, which is what usually spooks my internal medicine folks. So you can see early on here, 10-9, I think is about, I think that's when we started dialysis with her. She had that non-regenerative anemia. We started with a dose of darbepoetin, 0.5 mics per kg sub-Q, somewhere in this range, and we got a little bit of a bump up in the 30, kind of has gradually come down, and then we're starting to see the regenerative response wane again. And so did give her right before the CBC, or a couple days before the CBC, I think around the 1st, we did give her another 0.5 mics per kg of darbepoetin. And we've got a fairly robust regenerative response going on now. Her crit's not exactly where I'd like her to be from, getting her on the extracorporeal circuit, but she's tolerating this okay during the session.
But that hematocrit could be because you're kind of losing a little bit of red blood cells in the circuit, right? Because if you have that profound regeneration with the darbo, maybe it's not going up because you're losing a little bit in the circuit, or what are you thinking there?
I agree with you. I mean, I think, despite our best efforts, air versus fluid rinse back, all the rest of that, and being really mindful of, trying to get as many cells back, I absolutely agree that we lose some in the circuit for sure. I'm looking back through my sheets here, my treatment sheets, and I've got a pre-treatment crit of 30 and a post of 27 on one session, 24 versus 22.7 on another session, 23 down to 19 back on her very first session back on October 14th. So I do believe there is some loss there for sure. I'm with you, Andres, on that. It hasn't been a huge amount based on these pre and post crits that we're pulling on her though.
And you're not doing blood primes, I assume.
With this circuit, I'm not doing blood primes. It is, got the math here. It's about 11% of her blood volume in the circuit. So I think it's right at that threshold where I've been comfortable with where she's at, and she's always been in the mid-20s at least before putting her on. So.
And what's her blood pressure during dialysis?
Blood pressure comes down a little bit during treatments. It's, for the most part, though, has stayed hypertensive until we, again, just kind of seemingly reached that threshold for amlodipine that found the sweet spot for getting her hypertension under control. But it doesn't seem to be affected by the treatments and her blood outside her body in that circuit.
Nice. Yeah, great.
Do you guys, Andres, do you have a threshold, and it's multifactorial, obviously, what their crit is, what their body size is, what that percent of the circuits of their blood volume is? Do you have a place where you're more apt to blood prime, from a percent outside the body standpoint?
Well, I personally do it around 20%, even if it's going to be a low blood volume that you're going to have outside. I usually do a blood prime.
20% being the circuit, or 20% being their hematocrit, or both?
The hematocrit.
Yeah.
Yeah.
Yeah, I think that's what's been ingrained with me as well, and kind of from a standpoint of physiologically enough delivery of oxygen, like once they get on the circuit, it dilutes out, and we've got their extended circuit, so 18 is like my absolute lowest, but yeah, that 20% is a safer place for sure.
And you, as a criticalist, if you tend to have hypotension in these patients during dialysis, do you reach out for norepinephrine, or let's say the volume status is good, her her hematocrit is good. You are not ultra filtering too much. Do you usually go to vasopressors, or do you just adjust your dialysis dose, or what do you tend to do there?
Yeah, I've taken all of those factors that you just described into account, and I use my crit line a little bit for that too. You know, if I'm seeing that, because when I prime with a crystalloid, it's not going to, just like we know all crystalloids are, 75% or so end up leaving the vascular space, just redistributing. That circuit volume is, while I feel good at the start, well, we're not taking volume away because we've got a circuit that's got volume in it. But there does, based on crit line changes, seem to be some redistribution of that priming volume from the circuit if I'm using a crystalloid. So from that perspective, if I'm seeing trends towards hypotension, I start by trying to, take the change on my crit line, looking at my O2 sats on the crit line as well, and then saying, hey, I think I'm going to start with volume to just account for the fact that I'm seeing some redistribution. And in the days, I know it's a little bit controversial, thinking about a synthetic colloid, but I would probably start with crystalloids as volume. And if I was convinced then, to your point, that I was still experiencing hypotension and it wasn't an intravascular volume reason, then that's when I've reached for a pressor agent. And usually it's norepi for me as a starting place. I found that more in cats being an issue than in canine patients, even the smaller ones. But sometimes it depends, the most sick in the acute first couple of treatments. Some of the smaller dogs have also had that problem, but more often than not, I found that with cats.
Sure. Thank you.
Erica, do you have any comments on that?
No, I agree.
Great. And do you have any issues with blood flow when you reach out for your pressors?
I haven't appreciated any. Have you?
Well, not that much, but sometimes I do. Yeah, like
Yeah.
if you have a little bit of vasoconstriction, I noticed it just in one patient because actually it was a cat, and the catheter was in the caudal vena cava. So I don't know if he was getting volume depleted or if it was too much vasoconstriction, but it it wasn't that high of a blood pressure. So I was just wondering.
Just I'm just peeking around the corner at our ACT on this dog. She's one that so many of I've found most of our patients become a little bit predictable, as we get further and further out from the start. She's one that defies predictability in terms of what her response to similar dosing of heparin is going to be. She's currently sitting with an ACT of 273. Do you mind turning her down to 1.2 minutes an hour, please? But the last session, I think we were at the same bolus and same CRI, and she was just hovering just under 200. So she likes to keep us on our toes.
Yeah, I'm usually having a little bit of trouble with my heparinization also because I don't use an ACT because here is kind of impossible to get one, but I'm using PTTA and PT. And sometimes you have a good reading and sometimes you don't. So that makes it difficult. Yeah.
Yeah, I've really enjoyed. We've got the ACT Plus bedside, and back in Connecticut, my unit there, we had the ACT 2. I've been told by our warehouse folks that it's getting a little bit harder to get the little cups for them now, little sample cups. So I'm wondering if that's going to be something that becomes a challenge for us, and might have to look for a different option. But so far, it's been, probably besides the crit line and, maybe the platforms themselves, the ACT has been one of my favorite devices to have in this unit. We actually got a lot of discussion on Molly. I had a whole TPE session that I was going to share with you guys too, if something else didn't come up, because it was a tough one and an interesting one. And I don't know if 6 minutes will do it justice or not. But maybe what I'll do is let me see if I can bring up. I'll show you at least, and maybe it'll be a preview for 2 weeks from now, if there's some space to share some more in a couple weeks. But let me share Cole. I talked a little bit about Cole a couple weeks back here. And Cole was this, he was a little more crusty and aged than this picture. This is a picture that the owner sent me a little bit after the fact of his youth, his younger years. But he was a really bad non-associative IMHA that we did plasma exchange for. And like I said, I'll just start with what we got. I want to show you his timeline though, because I found it interesting and I want to see if anybody else has experienced this too. He was hospitalized with us for a couple of days, getting some standard initiation of immunomodulatory treatments, DECVECC, and eventually they started some mycophenolate for him as well. He had 2 packed red blood cell transfusions, and ultimately then became cross-match non-compatible with any donor units, as I think we've seen a lot of these guys do. And I'm going to flip through some of these again, just to kind of preview it for a couple weeks from now. One of the biggest things with him was his agglutination. And he was actually interesting because he came in for an ER visit at this time point, 10/17. And he came in for collapse episodes. And there was some concern that he was either having seizure versus syncopal episodes, but they did full blood work on him. And it's, easy. And he went home with a Holter and had a neuro consult and started some Keppra and kind of home for observation. But kind of retrospectively looking back, he had this spherocytosis and this pretty strongly regenerative response despite not being anemic. And probably, it's always easy to look back in time and say, oh, that CBC might have thrown up some red flags for us as to some kind of destructive process, hemolytic process happening already. He had just a titch above normal bilirubin at that point in time. Now, he declared himself a day later. He came back in for not doing well and decompensating. And so we only, we lost a day there. That's not too bad. And he came back in and was identified as having IMHA. He was now agglutination positive and, much more anemic. And so received his first packed red blood cells on that first day, was hospitalized and had a pretty significant drop in hematocrit again. Ghost cells, spherocytosis. His bilirubin was now climbing through the roof after those 2 packed cell transfusions, and continued to climb in the ensuing couple of days here as well, which is when they reached out to discuss plasma exchange for him. And we met him on our service, and I don't know how you guys have felt, but I find all of maybe it's my excuse for poor catheter placement technique, but I find my IMHAs tend to be so edematous. And just, this was a geriatric pug as well. In any case, I ended up needing to do a cut down to get his TPE catheter in, but I got it in. We had a nice placement. I reluctantly placed my polyurethane 8 French catheter, just given his size, and it actually held up for us okay. We did 4 treatments with him. we started off our first treatment trying to bring down some of that bilirubin as well with the addition of the vet rescue device in our circuit. And so we primed it separate from the circuits. And then once our TPE, we're doing membrane based on the Prismax, was primed and ready to go, then we integrated the vet rescue device in there as well. And that first treatment was one of the worst TPE sessions I have ever had in terms of alarms and pressures. And back on the TMPs that we've been talking about with the Blue Star, this membrane was getting so gummed up and our transmembrane pressures were just through the roof. And we ended up having to rinse back and start fresh with a new circuit. What we did for prime on this guy, back on Andre's question, I primed this circuit. It was quite a substantial amount, I think 18% of his blood volume. We primed this with fresh frozen plasma or plasma. But we found that we had to rinse back and change out the circuit about half an hour, 45 minutes in. And at first I was wanting to, attribute some problem to the vet rescue device being integrated in there. And I took it out and it still didn't help with our transmembrane pressures, and was doing my best to fight through all of that, and ended up just having to get to a second circuit on there. And we limped our way through that one as well. And what I found in our discussion a couple of weeks ago with the folks up at Tufts, and I forget, it was Cedric as well, really commented on just the high degree of debris floating around in these guys, and their hypercoagulable state, and the fibrin floating around just freely in their vasculature as being things that they've encountered, clogging up their pores and getting those TMP alarms. And in fact, Carolyn up at Tufts, described one patient, they had to change it twice. So they went through 3 circuits of the membrane-based TPE setup there. So what I took from that was that I need to invest here. They came back and said, we don't have that problem now that we only do our TPE on a centrifugal-based platform. So that's next on my list of to-dos, is to work on getting our centrifugal unit up to speed so that I can maybe avoid some of those challenges with the membrane based. But really quick, because we're out of time, this is what I want to show you guys. My patients really often after the first, if not after the first, after the second, have resolution of their agglutination. And Cole just kept agglutinating. And this is down at the lab, both so definitely cold samples at the lab, room temp, but even on our bedside agglutination assessment, had ongoing agglutination. And I really felt that despite us having a little bit of a stabilizing effect on his hematocrit and his bilirubin coming down somewhat, and his CRP coming down as well, I was still disappointed that we were still having agglutination even at this phase. And so we did actually do a 4th treatment on him and still had persistent agglutination and spherocytosis, which usually I have the spherocytosis. We eventually got out to day 13 and the spherocytosis resolved, but he was still agglutinating. And so I polled, a few of the folks on this group, and the general consensus was they would have kept treating with another TPE session. So we were ready and primed, given the fact that there was still ongoing agglutination, to treat him further. And I'll present the rest of this, another time when we've got more time as well. And unfortunately, he had an aspiration event and vagaled and rested. So we didn't get a chance to continue his TPE sessions, but we had some lovely committed owners who would have done TPE for as long as we suggested. And so that was going to be our first one that we were going to go beyond. 4 has been the most I've ever had to do in these guys. So we didn't get our chance to, but that's what I wanted to just kind of share, that this resistant agglutination that persisted despite those 4 treatments was a little bit of a disappointment / and it kind of broke me a little bit, because I'm so used to having that agglutination resolve after a couple of treatments that it's like, well, we got a real challenging one on our hands, and we're gonna persevere through it. But that was as far as we got. So I don't know. Final, Andre, you just unmuted. Yeah, have you had anything like that happen from your end?
Well, I was just going to say that it's really an interesting case, and I hope we discuss it later because it's a really good case, and I was just wondering about the anticoagulation and everything like that, but probably we're going to talk about it later. But how many or how much volume did you treat in the first treatments? And
Yeah,
because
all those fun
yeah, all
details.
those, yeah. But
Yeah, I'll
it's
tell.
really interesting case, yeah.
Well, if we're all back here again in 2 weeks' time and there's not something more interesting to talk about, I'd be happy to share all those details. Because because we didn't have financial constraints and he was a small enough dog, we used all plasma and some packed red blood cells for our replacement fluids, and we're actually able to do some pretty aggressive plasma volume exchanges, for me anyway. Some of them were 1.8, one of them was almost a 2 plasma volume exchange one session. So we were not light on our treatment outside of that first one where we had all those technical challenges.
So you still managed to do 2 plasma volumes in the first treatment when you lost the first circuit?
Oh no, I'm sorry. Not that first treatment. I was happy to get out of there with a 1.4 plasma volume exchange between the 2 circuits. That was the best I could do. But in the subsequent treatments, we were getting 1.8 to 2 plasma volumes exchanged each time.
Yeah, it's still a lot.
And to preview, there were some other folks, looking at it's a little bit of a double plasma filtration kind of approach. Always talking with Tufts, they will sometimes run the waste plasma through a filtering device and then use that as replacement later on. I've got some concerns around that. I'm hoping somebody from Tufts comes out next time, so that we can chat about that as an option, kind of a double filtration plasmapheresis type of approach. But we'll have to save all that for next time. And yeah, thanks so much for coming and bearing with all the alarms in the background. Erica, thanks for your help kind of talking through those. That was fun. We should all get together every time we have a challenging treatment going.
Yeah, thanks for sharing.
Cool.
Thanks,
All
Jethro.
right, thanks, guys. See you in a couple weeks.
Thank you. Bye.